Good afternoon, everyone. My name is Jim Pearson. I am the Deputy Chief Executive of Alzheimer Scotland, and I have the great pleasure of being here today to moderate this session run by TauRx and GT Diagnostics. And we're going to be joined today with three speakers, Dr. Sonya Miller, who is the Head of Medical Affairs at TauRx and the Chief Medical Officer for GT Diagnostics. Dr. Linda Somerville, who's the Head of Operations at GT Diagnostics, and Jeff, I hope I get this right, Jeff LaVaute? Yes. Head of Advocacy at TauRx. I should have checked that with you before. So this session is entitled Using the Patient and Carer Voice to Improve Our Understanding of their experiences of living with dementia. And I think that's really important because it sets a tone, I think, for what this session is about. And I know that my colleagues here who are in this session are very keen to have a discussion rather than necessarily a question-answer session, and to have a bit of dialogue with you around your experiences. On your chairs, there is a questionnaire. I know there are some people online. I don't think we managed to get into their homes and offices to place a questionnaire there. But here, those people in the room, there is a questionnaire. I'd be really grateful if you would have a look at that and provide some feedback. That would be helpful. And also, I think, throughout this presentation, to have a little think about what you might do to make a positive impact on the Alzheimer journey. And to think about how your voice as either a carer or a person with dementia, someone with experience of supporting people who are carers or people with dementia, how you might add to that understanding of the experience of people living with Alzheimer's disease for our colleagues here today. This is an opportunity for greater learning for them. So without further ado, I'm going to hand you over to Jeff, who's going to start with the first presentation. Have I got that? I know I'm not.
It's fine. I'm going to impersonate.
I'm going to hand you over to Sonya. Yeah. We practiced this several times. I should have known.
You didn't actually.
Thank you.
Thank you. A little height adjustment on the microphone is needed, so just bear with me. And I have anyone who knows me knows it's very risky to let me be in charge of anything technical, so I'm the first to use the buttons, so I apologise if they're not correct. Jim has already run through this for us, so we've already posed this question. And as he said, the questionnaires are there. Please, if you can, take the time to fill them out. And as he said too, we're really, really interested as you listen to our presentation today and the information we're sharing with you, to share your experience back to us. We'd like to know how it affects you, what you're listening to here, what sort of commonalities we might have, what differences. We'd be really keen to hear your thoughts and share your experiences as well. That's very, very important to us. I'm, as I said, the Head of Medical Affairs for TauRx. I've looked after all the patient safety in all of our global trials, so the patient is key to me as a clinician. We have been developing a potential treatment for Alzheimer's. It's an oral therapy, but today we are here to talk about our patient voice, and as I said, crucial for us. As a clinician, you learn not just to listen to what the patient's telling you, but what they're not telling you. That's almost as important. So the nuance is always there. And in keeping, as I said, with our core values and mission, we do really, really value what people share with us. It's quite brave for a lot of people to share their experience and share what they're talking about with us. I would like to really thank everyone for taking the trouble to come this afternoon, because I know it's a bit hard to make that long walk up this far for after lunch, so we really appreciate you being here and joining us for the session, and for Alzheimer's Europe for allowing us to be here as well. I have a short film to show you that involves people who have given their consent to share both their names and their stories with us. We start off with Martin and Stanley. Martin has been caring for his father, Stanley, who is a sprightly 89 years old now, and we've known him for the last 12 years as he's been living with dementia. We then have Jamie, who is a site manager at a very busy clinical trial unit in the UK that specialises in neurodegenerative trials, not just AD, but the whole spectrum of neurodegeneration. And we also have Dan, and Dan is a practising neurologist, not urologist, new with an N, in the NHS, also in England, and he is actively seeing patients with dementia, including Alzheimer's dementia, and also involved with research. So again, we posed 3 very, very simple but really critical questions to them. And these were, what happens? So what happens when you first get this diagnosis or think that you may have an issue? We then say what really changes for them, and there's a lot of change involved when you receive a diagnosis of any sort, and not necessarily things you signed up to in the first place or expected would happen to you. And then what matters? So what really matters to them on an individual level? So I'm very honoured to be able to share their thoughts and insights with you. And as I said, I hope that you can then, as you're listening to what they're saying, be able to share in a discussion with us later about your particular thoughts and comments on that as well. So I'm hoping this film works. If I click, there we go.
So, I guess the first time I found out that Dad had Alzheimer's was Christmas, I think in 2012, and Dad just sat down and said one day that he'd been diagnosed. So it was a little bit of a bombshell, and it was a bombshell for Dad as well. It was a lot to take on. So, because I'm a bit obsessive that way, I googled everything I could find so that I could find out the magic cure, but sadly there wasn't a magic cure, and it was all a little bit bleak.
You have the patients that are affected, and quite often they're just the nucleus of a much wider support network. And it's the caregivers who are often asking a lot more of the questions, and so being able to have the time to speak to them and to help them understand what the diagnosis of Alzheimer's disease or dementia might mean or might look like for them in a year's time or in 5 years' time is quite important to see how they can help their loved one.
Everybody who comes through the door is unique in their life circumstances they bring, their family, their work, and all the different life events that might be influencing the symptoms that they're coming to see you about. And unlike other branches of medicine, assessing someone for dementia it doesn't involve looking at scans and test results. It involves really delving deep into someone's life and their story, and so as part of that process you kind of get to know someone to make the diagnosis, and that is a unique and privileged position. You sort of almost making a friend every time you assess a new patient.
People often say when we're out, oh, this is lovely. You're so amazing. Oh, you do such a great job. Dad and I went with a friend of his into Marks and Spencer's recently, and the 3 of us walked in holding hands, and the lady walked up to us and went, I don't really know what this is, but can I just tell you it's making me cry because it's so lovely. And off she went, and it's really sincere and really lovely. And lots of people say lots of nice things. But then you go home and there's not somebody there cheering you on, and things are not as ideal. And when you're looking after somebody, I guess the impression you get when you hear somebody else in that position is, oh, they're doing such a good job because they're doing all these things, and oh, that's wonderful, it must be so appreciated. And actually it's not always appreciated, and quite often It's the opposite of appreciated.
Especially early on, people are quite scared and quite intimidated to understand about their memory and their cognition. And so when you're speaking to patients who don't necessarily think they should be bracketed in with mild cognitive impairment or even Alzheimer's disease or bigger dementia with the other conditions, it can be quite an anxious time, and people who associate themselves and see themselves in a certain way will then have to start seeing themselves in a different way.
I think that people really appreciate an open and honest approach right from the beginning. I think it's that most people don't want concerns hidden from them, they don't want prognosis hidden from them. But the challenge is to deliver that news in a way that is compassionate to them, for them. I think post-diagnosis people want to feel connected, and we have to work hard to not leave them feeling abandoned. Given a diagnosis and then abandoned. That doesn't mean just the doctors and nurses in the service, but also all the other groups and communities in the area that support people with dementia and with Alzheimer's disease.
It's easy to be frustrated, but it's frustrating for Dad as well. It's not that he's a passive recipient of all this loving care. It's frustrating because it somehow underscores that things have changed. So I think acknowledging that things have changed and some things are different in a way that we mightn't have chosen them to be. But it was like, come on, we're going to do this. And it's not going to be as bleak as all that. We're in it together, we're going to have a good go. And I think that was a really important moment. I remember being like, it's going to be okay.
So that's Martin, Stanley, Jamie and Dan. As you gather, Dan was a little bit camera shy when we were doing this, so chose just to speak to us instead. But I think what strikes me all the time is the brutal honesty that they all display there in discussing this, especially Martin and Stanley, but also the hope that comes through, that you can beat this, that there are things to be done, and that there is an entire ecosystem that's affected. It's not just the patient, as you all well know. It's the patient, the family, the carers, the colleagues, the friends, everyone they interact with. And I think that we always make the assumption when we work in this field or in research or in support groups that everyone is well supported and well connected and well informed. But in fact, you find that's not the case for a lot of people. So there's still a lot of work to be done in letting people know there is the support and the outreach. And this is also, as I said, a big driver of why we listen so intently to the patient voice. I'll be handing over to my colleague Jeff, who will be presenting now some really interesting information about a UK patient and carer workshop, where they also share their thoughts, comments and experiences with us. So thank you.
Thank you, Sonya. My name is Jeff LaVaute, and excited to walk you through how we think about the patient voice, and the patient voice is so important to all the work that we all do in this room. And I think this week, some of the themes and some of the points that we're going to be discussing, we've heard it throughout all of the sessions. The sessions have been fantastic, and all the credit back to the Alzheimer's Europe for bringing us all together, and appreciate this opportunity to talk about why we think the patient voice is so important. And you started to hear this with the story of Stanley and Martin, and I've had the pleasure of hearing their story live. They're just so captivating, and anytime that you have the opportunity to interact with patients and carers, that's so important. That's something that we need to do more as industry, and you'll hear me kind of make this point as I go through these slides. As we think about the patient journey here, and we heard it in the video, we've all lived it, we've experienced it. The journey begins with some sort of a sign and a symptom. You know that something's going wrong. You kind of have an idea of what it is because it's probably something that your parents or aunts and uncles or grandparents or someone has had in the past. So you sort of have this idea of what's happening, but still you're going through it. And we heard Martin talk about that moment that his father sat down and said, there's this diagnosis, and he was paralyzed, and that's a traumatic event. And we have to recognize that for the patients and the carers as they're going through this experience in their journey. The first thing is they're paralyzed. They don't know what to do. And we heard it with Martin. He Googled. We'll talk about that in a minute. But that's human behavior right now. And then they're going to go through this cycle. And this was based on some research that colleagues of ours published a few years ago. It holds true, not just for Alzheimer's, but most major conditions, in our opinion. But I think it's absolutely relevant here. So you're upset. You're trying to understand what's happening with the diagnosis. You're numb, you're lonely, you're devastated, there's a lot of fear and anxiety that's happening. And you're cycling through, and all of these emotions happen before you've even gotten to the point with the physician where they're saying, okay, there's a treatment option. United States, there are more treatment options that are available. Elsewhere, there aren't treatment options yet, especially if you're diagnosed with MCI. So there's this fear of, what do I do? We heard it in a session yesterday. There was a patient that at the end of the day, he got up and he made the comment about how he's under 65 years old, European, under 65 years old, and the doctor basically said to him, you're not 65, so here's your diagnosis, and come back and see us in a few years. There weren't services available to him. I'm paraphrasing what he said, but it caught me as I was thinking about this. So these patients go through this cycle. If you're over 65, there's more services that are available. We'll have a conversation later about, are those services designed for the patients, and do patients actually have access to those services? So you go through this whole process, this journey continues. And one thing that we do know about the Alzheimer's community is that patients and caregivers are working together to support each other. That's why we're here this week, and that's something that holds true across the community, regardless of the country that we're talking about. Whether it's in the United States, it's in UK, it's in Europe, it's in other countries. They're building these communities, these small micro communities, to support each other. And they're exchanging information. And that information is affecting how they think about their decisions for treatment. What can I do, right? What are my options? What services are available to me? So building these communities, this is based on some research that was published a few years ago. 83% of people trust recommendations. They trust information that are coming from people who know, right, and have the same condition. So there's that trust and that credibility factor. A lot of times patients are going online, or carers are going online to look for information, right? 91%, over 90% of patients are Googling first. That's what Martin did. And 70% of carers are looking for information and support online for their loved ones. The statistic that's not on this slide, and we're going to talk about this in a minute, is that carers need support too. So they're trying to understand, how can they help their loved one? What can they do to make informed decisions about their loved one? But they also need support for themselves, for their health conditions, and also for adjusting to this new reality where their loved one now has cognitive decline. What do they do? So peer influence can really change patients' beliefs and behaviors. We know that for a fact. It's kind of why we're here. They want authentic information. So a lot of times when they're looking for information, they want to know that it comes from a trusted source. And they want to know that that information is relevant to them, and they connect to that. If it's authentic, they'll believe it. If it's authentic, they'll use it to help inform their decisions. If it's not authentic, right, then it actually kind of turns them off, and we have some research on that I'll present in a minute. So we want to make sure when we're designing solutions for these patients, for the carers, it's authentic. The way that it's authentic is to hear directly from the patients. We want to hear what they need, what their experience is, and use their voice to inform our insights and inform how we design solutions that we all want to design for people living with Alzheimer's disease and their loved ones. So from an industry perspective, and now I'm going to speak on the industry side, we often think that patients should follow the journey that we want them to follow, right? So patients are going to go through a journey that suits our needs as industry. That doesn't work. It's a flawed assumption. I could go on and on about how that does not work. And I think that as industry, and I'm speaking, representing town, representing, over 20 years in the healthcare, working in healthcare, we can make smarter decisions about what we can do for patients and carers by listening to them, by listening to their voice, by not relying on scripted testimonials and scripted journeys, right, that we think that they're going to follow. And that's so important. We heard this again from Martin, the conversations, he didn't have hope, right? So as soon as that diagnosis came in, and I'm sure many of us have experienced this firsthand or in our work, it's just the conversations that are out there. As soon as you get that diagnosis, right, the doctor isn't going to give you, sufficient information to kind of instill this idea of hope. They may not. By and large, in the research that we find, we hear these stories of we've been diagnosed, go away, process the diagnosis, and come back, and then we'll talk about what to do, right? But then you're sending people away with this, diagnosis that is devastating their world. We conducted social listening research. So social listening, this was conducted in the United States, January 2023. And what this allows us to do is to go in a blinded way, so we don't get identifiable information about the patients or the carers, but we can go into communities, we can go into postings that are online, publicly available information, and we can find out what types of conversations that they're having in these communities that they're using online resources to find. And they're connecting to these different communities. They're looking for that authentic information from the people that are living with the diagnosis that they're living with too. And what we found is that, anytime that there's a hopeful conversation that's out there, it's industry driven. And we know that there's so much investigation into, really, really interesting, science and treatment approaches that are going to help these patients. So industry is pushing that out. That's where the hope comes from. But from a patient and a carer perspective, what they're hearing is that there isn't hope. Maybe the doctor is saying that they're not appropriate for therapy. Maybe they're saying go find a clinical trial. Whatever that message is, what we've found in our research is that there isn't hope, right, in that conversation. And that's an issue because you're trying to understand how to change your life, right, and process through that whole cycle that I just talked about. And the first thing that you're hit with is negative information or something that's not optimistic to help you figure out how to change your life, right? How to make the decisions that you have to make now, how to make sure that you're doing right, for yourself and for your family. So there are things that we can do better. The top fears, and we've heard this all throughout the week, and I'll go into this a little bit more in a minute. Carers, they want to be heard and they want to be understood. And they feel guilty for expressing. If they get frustrated with their loved one, or if they're concerned about how their loved one's diagnosis is going to affect their life, they don't want to say it out loud because they're holding back. Now, I understand it from one perspective, but let's think about the impact of the carer. And so we have to create solutions and create this sort of safe environment to support carers so that they can process through the decisions that they have to make and also how that's going to affect their life because it's affecting their loved one, it's affecting their life. Patients are most worried about being a burden, right? And again, this isn't necessarily new, but it's so important for us to understand. Patients don't want to be a burden. We've heard firsthand through some of the work we did with UK, in the UK, patients and carers, patients want to just kind of go back in the shadows, right? They don't want, as soon as you're diagnosed, you don't want to be a burden on anybody. And that's also not fair because, going into seclusion is not the answer. So why is all of this important? Every patient's journey is different, and every voice matters. If we think about that, then it isn't a one-size-fits-all approach to how we can design solutions that meet the needs of people that are living with Alzheimer's and their loved ones. Sonya mentioned that we had conducted qualitative research. Qualitative means, we're just interviewing them, we're spending time with them. This was an online session that we had with patients and carers living in the UK. We conducted this 2 months ago and got some really interesting insight and perspective from these folks. The next, some of the images are actually images of the people that participated in the study. One of the takeaways, right, that we have, and one of the things that we think about, in our role, trying to support patients and carers, is that, in order to put the patient first, you have to really, make an effort in what you're trying to do as you're designing solutions. You have to make that effort to purposefully put them first, not just say it, but actually do it. And that requires a high level of emotional intelligence, because it's not just hearing, right? But it's observing, it's watching, it's learning, it's being able to experience what they're experiencing so that we understand. And we have to be, it's not just empathy, it's something that's higher than that. Because if we don't do that, then we don't have those actionable insights. And if we do that, the converse is we have actionable insights, we know how we can help them along their journey. So we listen and we learn. And we tell authentic stories in their voice. The best stories that are told are through the patient's voice, using their words. The way that people living with Alzheimer's talk about their diagnosis, they talk about their life. If we listen, we can learn, and we can apply that learning, right? And it helps us be more, design solutions that fit their needs, but it also helps us to design solutions that resonate with patients because we're talking in their same voice. And so we design resources that meet their needs and not just our desires. I'll walk through quickly some insights from this research. So patients and caregivers, and we kind of, we grouped this all together because we bucketed some of the things that we learned and some of the things that they were telling us into 3 groups. So it's functional, cognitive, and then emotional or social. And this, we heard a lot of similar things. They use different words, but similar themes from the patients and the caregivers. On the functional side, right, what happens when you are living with Alzheimer's? You have a lot of functional, changes to your life. You have cognitive changes to your life. You're forgetful. You start to be disoriented. You start to be confused. And then emotional and social, right? You're depressed. You're anxious. You don't want to talk to people. Sometimes people don't want to talk to you. We've all heard the stories of someone that's diagnosed, and you have groups of friends that, lean in. And they don't just say, I'm sorry for your diagnosis, but they actually lean in and say, how can we help? How can we spend our time with you the best way that we can, right? Knowing that for the patient, they're going to change. That's what happens. They change. We're going to lean into that. But then you also have the group of people, right, in social circles that walk away and say, I can't. It's too much. And that's fair. But it's kind of not fair to the patient and to the carer. And so these are the stories that we're hearing. In terms of diagnosis, and I love this first quote. I'm not going to read all the quotes, but I'm going to read this first one. Fight starts today. So we had a patient who was talking about the way that he felt when he was first diagnosed. And he said, you have to fight this bloody thing head on. You can't just cower in the corner, but you have to say, okay, this is the diagnosis. Now what do I do? Right? Losing oneself really does affect everyone. So again, we know that people living with Alzheimer's, they do change, right? It changes people's lives, and it affects everyone around. Not losing hope is a struggle. And we heard that from Martin. We've heard that through some of the research. And that isolation can quickly set in. And so thinking about what do we do? What's our takeaway from that? Alzheimer's is invisible. There is no external way to look at someone and say, okay, they have Alzheimer's disease. They're living with Alzheimer's disease. But yet they're behaving in a certain way. And we see it. So although they look the same from the outside, they're not the same person, and it's not their fault. This is not something that somebody has done. This is something that just has happened for a lot of different reasons. And the system often leaves these patients, these people living with Alzheimer's behind, right? And society doesn't understand. And these two statements hold true regardless of the country that we're talking about, right? The system isn't ready to really to provide the support that the patients and the carers need. Society doesn't understand, and yet managing Alzheimer's is a team sport that's so important. It takes a lot of people, and it takes a network of support, both for the patient and the carer. So the burdens of navigating the healthcare system are high. That's an obstacle. And finding a balance is critical. So everyone wants to do their best in this situation. We hear that from the patients, we hear that from the carers, we hear that from industry, we hear that from all of the associations. Everyone is trying to do their best, right? And everyone wants the best for their loved ones or the people that we care about. You know, if we're on industry, if we're in, you know, working in associations and societies, we care about people and improving the lives of people who are living with Alzheimer's disease. That's why we're here, right? So we're all trying to do our best. So success comes by instilling hope and community. Hope in the community. We can instill hope in the community. We can help people, right, by how we act, how we support them, how we design solutions, how we engage them. Right? Think about the way that we answer that question that we heard Martin, you know, talk about. His father was diagnosed, and the first answer was, "I'm really sorry," when he said that to someone else. Right? That's not instilling hope. Right? We've all heard that before. It's okay. How can we help? How can we learn more about it? How can we instill hope that there are options out there? This isn't the devastating disease that makes you just cower in the corner and that's it, because that's not fair. And we can create communities, right, where people can come together, people can find the support, and we can all play a role in that community. And we can think about how we can do better. This gets back to the question Jim asked. So why does this matter? We've talked about journeys. We've talked about, I talked about the cycle and the way that people, process a diagnosis, and they process, kind of what's going on, the changes that are affecting their life. But why does this matter? It matters because each journey affects people, affects their family, affects the physicians in different ways. So it's not a one-size-fits-all approach. It can't be. Now, can't also be, millions of different individualized approaches. So that's why we have to listen and we have to learn. We have to understand the community. I keep repeating that because I think it's so important. It's their voice, it's their stories, it's their experiences. When we process those, we can design solutions that help them where they need the help. We can deliver content to them where they look for content, online or in person. Jim talks about, manning the 24-hour resource line. That is a great service for people that know about it. But if you don't know about it, there's so much good information that's out there. And if people don't know about it, then we're still doing a disservice to the people that are living with Alzheimer's, their carers. So as they go through this process, just remember that everybody's journey is different. Everybody's voice is different. The way that they interpret that journey, the experiences that they have, the emotions that they have, that's their own. And it's on us to understand that and then think about how we can help them as a whole. I'm going to ask Sonya to come back up, and she's going to reintroduce Martin and his father, talking about diagnostic tools and ways that we can be more effective there.
Tool of power again. As part of the whole process too, we need to look at how we have outreach into people in their homes. And part of that is about thinking about more flexible, intuitive, clever diagnostic tools. There was a lot of talk, and you all know about the blood biomarkers probably. They're still invasive, still expensive, still not clear on the guidance of how you use these to establish a diagnosis or monitor disease. CSF is invasive, PET scans are also expensive and difficult to get. There's a whole plethora now of things that are trying to help the diagnosis, help people monitor. But what we need to do is get into people's homes with a tool that they're happy with, that they're comfortable with, that they don't find threatening, that's not pass-fail, that is something they can use at their own pace and share with their family. So another question I was asking people that we were talking to before is, if you could diagnose yourself, if you could design a diagnostic tool, if you could describe what you would like to use, and this applies to everyone in the room, I'd like you to think too, how would you answer the question? What would you like as a tool you could use at home to help think do I actually have an issue with some of my cognition or not, or am I just worried? And if I did, or if I did have a diagnosis, what would help me, maybe? What would give me some reassurance or some idea of how I'm going over a longer time period? So I pose that question to Martin and to Jamie and to Dan once again, and we will share their thoughts on it now, again in a very short film, which I'm hoping comes on.
It would be a lovely thing if there was some sort of diagnostic that you could use early in the process and that was less intrusive, so that you could, go and do your quick test. It's all very jolly. You get a result, you know where you are, and it would flag up issues early in the process.
From a psychological assessment point of view, the psychometrics at the moment are quite intense and can often be quite different depending on how you act and how the patient is with the assessor. So to be able to try and find a niche where you obviously get a place or an environment where it's not too stressful on the patient, that they can keep performing and feeling at ease and calm so they can get an accurate representation of themselves.
People with Alzheimer's disease often like to know how they're doing, how their disease is progressing, and to have a feel for the rate of change. And providing that information can be really challenging. The tools we have traditionally are quite blunt for measuring cognition. And so I'm really hopeful for a future that involves more sophisticated tools, assessment at home, the involvement of artificial intelligence and machine learning to provide easy to administer and easy to use tests of cognition that will guide both the clinicians, how a patient is doing, but also a patient about where they are, at what stage in their disease they are at present.
It's useful for me to see how we're doing, because I know how we were doing last month and how we were doing last year. So it's a good yardstick for me to say, oh, did really well at maths today, that was amazing. Diagnostic tools I think are useful and really interesting, but you don't want the tool itself to make you feel terrible about yourself.
So I think for me, some key takeaways there were not to feel terrible about yourself. These things are supposed to help and encourage you to engage with your disease process and what you can do about it. And also the where you are, that's so important for people, everyone's story and where you are. I'll be handing over to Linda now, who can give you a lot more insight into the current field in therapeutic diagnostics. And hopefully, as I said, if you can think about what would be important to you as individuals also for the discussion after Linda's section of the talk. Thank you.
Yes, my colleague Jeff, he was talking about the journey after diagnosis and how emotional that can be and going around in circles. But for many, many people, that emotional journey starts long before the diagnosis. When they have first symptoms, it takes a while to get to the diagnosis. And for some, it starts even earlier. You start to worry because you have a family history, or you've seen friends who live with dementia, and you're worried, will that be me someday? So really, we're looking at a long journey there as well that people need maybe help with or want some guidance on. For this presentation, I've been looking at the World Alzheimer's Report from 2021, so Alzheimer's Disease International. They do a great job at pulling together each year a report on a different topic, and 2 years ago that was on the diagnosis. Don't worry if you can't read anything on these individual images. I have a slide on each of them. So we'll go through these aspects as part of my presentation. Yeah, so they've asked to pull this together. They've taken the opinions from over 1,000 clinicians, just above 200 patients, and more than 2,000 people caring for someone living with dementia, and then put that together. And what's on these slides are some of their key findings from this. And it's a worldwide study, so there's over 100 countries involved. So you really get a big picture image, and not just from where you are yourself. The first big finding was that 75% of people globally who are living with dementia are not even diagnosed at the moment. And that, well, if you calculate that then based on the world population, that equates to 41 million people being undiagnosed. Now, what we've done in this image on your right, my left, with these people, we've just said if you have 500 people out of the ones over 45, then 3 of those people, according to the statistics, are diagnosed and living with dementia. There's another 9, that's the 75% who are not diagnosed. And if you look further into something called Braak staging, which you can only look at post-mortem, but you can then extrapolate and estimate how many people that would be, there's another 90 people who've got some initial changes in their brain that might not show as symptoms at that point, but that are sort of a precursor to what might lead to dementia later on. So there's a lot of people who will really want to know where they're at. And that's where the early diagnosis starts, but what makes sort of the extent of where we're trying to target. The second statistic I wanted to draw your attention to is that back in that study that ADI did, 33% of the clinicians said they believe that nothing can be done about dementia, so why bother? Well, of course, that was 2 years ago. Since then, a little bit has happened, or a lot actually. Of course, there's non-pharmacological treatments, and they were available also then. New pharmacological ones become available more and more. And also this year's ADI report, World Alzheimer's Report, focused on modifiable risk factors. So there's really a lot that can be done, and if nothing else, it is knowing what's wrong with oneself, which a lot of patients just say is so important, to give this feeling of something's not quite right a name, to be able to say, I have this, and that's why I keep forgetting things, or that's why I get things muddled up sometimes. Time pressure, the pay-per-visit models, that's a big issue as well. The doctors are rushed. We've done something similar to the videos you've seen here also in the US, where someone said, the doctor is always rushed. I forget what I wanted to ask, and then I go home, and that's when I remember. So I think we've all experienced that, going to the doctor. A lot of the times, especially if it's a busy time of year with colds and flu going around, they don't really have much time. So what can we do to help them? New tools can maybe help. If they're less time-consuming, that means there's more time for the medical professionals to interact with you, to speak with you. If you can maybe do some assessment at home that can reduce the wait time between your appointment now and your checkup in 6 months, a year, whenever your next checkup is. You could see in between how you're doing without having to wait till you finally get to go to the doctor and do another test. And of course, if they're easy to administer and easy to use, that was also some of the points you see here is what we heard in the video earlier as well. Yeah, if they're easy to administer and easy to use, yes, then there's not a long process of explaining how it works, not a long time-consuming process for the medical professional to figure out what the results mean. It can all be done quicker. And of course, that was also one of the points from the video earlier. They shouldn't be too stressful on the patient, because then you're stressed, you don't perform as well as you would when you're relaxed. the barriers to diagnosis that have been identified by people living with dementia and also the carers were that half of them, or almost half, 47% is almost half, almost half of them that said lack of training of the clinicians, and also almost half of them said fear of diagnosis and stigma. What can be done? Well, if you look at the lack of training as an issue, the first thing you think of is, well, increase the training opportunities. And I completely agree. That's very important. But it's not the only thing that can be done. It could also be that you develop tools that are easier to administer and interpret, and therefore you reduce the time needed to learn how to use them and to learn how to interpret them. And to some extent, I believe that the stigma aspect can be addressed just to some extent, not completely, by allowing to test at home, by having people do an assessment at home when nobody is watching. Or maybe if you want to, you're worried about a loved one, a family member, or maybe a close colleague. You maybe can't get them to go to the doctor, you can't drag them there, but you might be able to convince them to do a test at home that they can do to find out if there is a need to go and see a doctor. Yeah, 75% of the clinicians in this ADI study, they said that as the global population ages, the increasing number of people seeking a diagnosis will be a major challenge in the future. So one important idea that we had on this statistic was that it will really be good to streamline the process. So if you were to start at home with a self-administered test, then people who are worried but actually well, we call them the worried well, they can be put at ease. They can see, oh, this is actually normal, I'm okay. And on the other hand, the people who are worried and then find out they're not well, worried unwell, they have data that they can then take to their appointment when they go and see the doctor. So it's not like, oh, I'm forgetting things more often, I think maybe something is wrong. I've done this test, this is my score, what is our next step? I would say even, yes, a lot of changes in memory or cognition, they are slow, they're maybe not easily noticeable at first. So if you have something that measures it at home, you'll be able to much more easily see smaller changes. So an earlier diagnosis, an earlier intervention might be possible. And of course, the next steps are then to triage and streamline so that only those who really need it are referred further to one expert after the other, because they maybe have a very complicated case or there's other things that play a role in their particular case. But we don't all have to go through the exact same steps. It should be more personalized, more streamlined. Yes, and the last one of my statistic links, the last red box from the ADI report, was their sort of overarching statement that the globally aging population plus diagnostic and treatment breakthroughs, that will create a tsunami of demand on the healthcare system. And I think it was just considering how can we help the healthcare system. I personally find it highly unlikely that we could just pause healthcare for a week or two and train everyone on something new and then say, okay, this is how you do it from, next time onwards. Probably not possible. So I personally believe there should be a gradual change. So the tools that we develop should help step by step and evolve as the change happens and not be something plucked on to medical professionals that they haven't seen before, that doesn't tie in with their processes, and all of a sudden, somehow that's how they're supposed to do it from one day to the other. Or by pausing the system for 2 weeks doesn't really work. Yeah, so tools should be designed to support and enable a gradual transition. And hopefully with our ideas, and I'm very sure there will be a lot more ideas in the room because you all have your own journeys, your own expertise, you will have other ideas than we had. But hopefully if we all work together, we'll be able to redefine the patient journey and help in that. While we do that, we'll also help the healthcare system, because if it's not a long and winding road for the patient anymore, it also reduces the burden and the load on the healthcare system. Yes. As a last slide, I would also like to just very briefly introduce you to the tools that we at GT Diagnostics work on. This is not a sales pitch, so I'm really just putting up this slide, tell you we're working on different tools. And if you want to know more, please come find me or my colleagues afterwards. We've got HiPAR, which is a home assessment tool, HiPAR Pro, the professional counterpart that can be used sort of in the waiting room setting. Psychox, computer adaptive cognitive assessment, and Signex is Psychox and Signex still in development. Signex is based on EEG data. But with that, I'll finish my part and we'll hand over to Jim to lead us in a discussion where we very much appreciate your input.
Thank you.
That's probably my phone, is it? I don't know, it's probably mine. I looked at my handbag. It's always the way.
Good, so thank you. I'm just checking in this iPad because there are 22 people online as well. No questions so far. So, thank you. You've heard those really interesting presentations, and I think, as I said at the beginning, for me, I think what was really important about this session was, I think, a really genuine desire from our colleagues here to actually hear from people with lived experience of dementia, either as a person who's a carer of someone with dementia or a person who's living with a diagnosis of dementia. And I think that, for me, is hugely encouraging. And Jeff mentioned earlier when he talked about that assumption sometimes made by industry. And I think actually an assumption is not always just made by industry, but sometimes in our health and social care systems, about an expectation that people will follow a pathway that clinicians or others, that a predefined kind of pathway, which might be in some ways impinged because of the structures that are there and stuff. And I think, so I don't think that is only an issue for industry, but however, it is massively encouraging, I think, to hear that acknowledgement of those assumptions and a commitment to doing something different. So thank you. So this session isn't, I know, question and answer, but I don't think we want it necessarily to be a question and answer. I know that Jeff and Linda and Sonya are very keen to be hearing from you in any views. So is there anybody in the room got anything that you would want to add, a comment to make, or indeed a question? And for those of you who are online, if you want to pop any questions, then I'll pick them up here and can add them. So, first one. So I know some people in this room. This is Graham. Can I just say, Graham's almost as tall as me, but not quite.
No one's as tall as you.
No. Thank you.
Yeah, a couple of thoughts. So when we're looking at that triumvirate of symptoms that Jeff was talking about, the functional and the cognitive symptoms, we can't prevent, we can't do anything about the progression, but we can help people adapt and adjust to them. The emotional and the social symptoms, I say absolutely, there's things we can do to stop them ever happening quite often. And if we look at that cycle after diagnosis of anger and hopelessness and despair, I would say that a significant amount of that is caused by the doom narrative around dementia. And Jim, you'll be aware that there has recently been in the UK, as we say in Scotland, a bit of a rammy on Twitter over a very powerful but very dark and despairing advert that dementia research in the UK did. The Alzheimer Scotland, I think, quite rightly came out and challenged and said that that's not the kind of narrative we need to be driving as large organisations. That was then followed up, I don't know if you saw Kate Lee's piece, who again said, well, we need to do this to raise money, which I thought was absolutely shocking, frankly, that large national organisations are admitting they're driving this doom narrative around dementia that is causing a lot of these issues post-diagnosis. Second thought is, if we are going to start diagnosing people earlier, and we're going to have this huge wave of new people getting a diagnosis at a much earlier stage, and we're still having this doom narrative, what support is there going to be for people? So the one thing that I didn't see mentioned anywhere in this is community, and where community comes in. And we have a very strong dementia-friendly community network in Scotland. We have Alzheimer Scotland resource centres. We increasingly have meeting centres. To me, they are a missing part in this puzzle, because community is where you deal with that. They're the people who catch people after they fall after diagnosis. Yeah. It doesn't have to be a clinical process. Communities have a huge role to play in that. So I'd just like to hear the panel's thoughts on those kind of two issues.
Yeah. Okay.
It's all brilliant things that you brought up, and like any health initiative, you need a massive buy-in. There's no point, as we've been saying, dictating, this is your treatment pathway, this is what you do, and this is how you monitor. You need the buy-in, and your thing about community is bang on, and that's what we were trying to say. It's a whole ecosystem. And in health in general, us as clinicians or the doctors in the hospital setting, whatever, we see you for this amount of time, but your family sees you for this amount of time, and the community you interact with sees you for that amount of time. So if they can't support you or they don't understand the process, that just will fail. And in a lot of the interactions I've had with patients coming in to be assessed, one of the really, or just as important, is talking to their partner or their husband, wife, carer, son, daughter, whatever, to help them understand what's going on, to say there's no point correcting them all the time, there's no point being angry, they're not doing this deliberately. This is a process where you're backing yourself into two corners that won't meet unless you can understand the process. And it's incumbent on the partner more so than the patient and the community, as you're saying, to have this understanding, to have this buy-in. And you're right, this sort of doom message is so counterproductive. If you want people to come out, not be stigmatised, address the issues, get the early diagnosis, we absolutely need that more positive message. And this is why we are getting out there trying to say, this is what patients want, this is what they actually need, this is what all their people involved in their lives need, and it's crucial. And some of these diagnostic tools we're talking about getting into the home, that involves the family. You can sit there, you can do these like wellbeing apps together, and any disease process is going to need multiple therapies, multiple diagnostic tools, multiple pathways. Think about hypertension. There's about 10 different medication sort of with modes of action, different modes of action you can use, and dementia's the same. And it's coming. It's the tip of the iceberg sort of being reached almost. We're getting over that hill, if you like. There are more and more therapies coming targeting more pathways. The amyloid, the tau, the inflammation. Alongside that is all of these sort of the other things that support the 12 modifiable factors that Linda shared from ADI. And these are all crucially important. There's never one solution, but your comment about community is crucial. And we are very aware of it. But again, we're based in Scotland. We're a very small company. We were an R&D company, research and development, and we've sort of become a pharma by default because we've got a drug that is good. That's as much I'll say about it at the moment. But, we are very, very focused on that community, family, all in, everyone's involved. And as I said, I looked after the patient safety through all the global trials. So I know every single patient all over the world that was involved with our studies. And that's really important to me, to us, to all of us here. So thank you for that comment, because that is crucial, and we're very aware of it.
Jeff, you wanted to respond to?
Thanks, Jim. So just to add to that, and we talked about this a little bit before, as we're starting to push, more our ability to diagnose earlier, and there are treatment options that are either available or becoming available to help people who are diagnosed earlier on, we have to understand that the resources, the support, the education, the way that physicians talk to patients when they're diagnosing somebody with mild or moderate Alzheimer's, that's not going to be the right fit for how they can talk to somebody, or the resources that are available for people that have MCI due to Alzheimer's. Right? So it's a really important question, Graham, that you're asking, and we have to acknowledge that the existing support structures that are out there for people living with Alzheimer's aren't necessarily the right fit as we start to push into earlier diagnosis. And if we think about that now, I'm going to take this back, American adage, if you build it, they will come, right? So if we start to put in those diagnostic, more earlier diagnostic tools, and we're getting people diagnosed earlier enough that we can have, some positive intervention, we need to design solutions that fit their needs, not assume that the solutions that exist today are going to do that.
And I think you're in for the long haul. You know, this is not a disease that you diagnose, treat, it's all done and dusted in a week, cured. You're not just excising a lump or something. This is a long haul, and people who have MCI may stay very stable like that for 15, 20 years. It's not an automatic, oh, I'm going to deteriorate to this point. It's a very, very individual trajectory for every person. So this is a long-haul solution that's required, and that major change in attitude, as you say, right down from policymakers, right down to community base, to understand it's something we all need to do if we're going to live well as we're living longer. It's really important.
Okay, thank you. Does anyone else have it? Ruth? Sorry, I don't know everyone in the room.
Sounds like it.
You were impressed for a minute there, weren't you? Yeah.
I also don't want Scotland to dominate the whole agenda, so maybe if I'm asking another Scottish question. I suppose I just want to recount a story that happened just last week. So we have groups of family and friends who come together, and we have some young people in our groups who are adult children of people with mainly younger onset dementia. And we're a really positive group. What Stan does in relation to peer support and the atmosphere we create around our meeting centre spaces is the most positive thing you could ever imagine for people living with dementia. And we had the family and friends, and the three young people were talking about genetics and all that kind of stuff, about what their risk factors are. So I'm spouting forth about, you know, get yourself down to the Alzheimer Scotland, you know, brain health hub in Kirkcaldy, get yourself tested, you know, there's all sorts of modifiable factors. I'm giving them all this information. And one of the girls said, why would you want to know it's a death sentence? Yeah. And we are trying to support her mum. Her mum's living well, she's living on her own, she's got a couple of dogs, she's coming to Inverness for the Dementia Arts Festival. This girl still saw it as a death sentence. So I think we've got a long way to go to shift attitudes and stuff like that. And so we are in for the long haul. So,
thank you, Ruth. That gives me goosebumps when you say that there's this sort of prevailing attitude is still there despite our best attempts to get rid of this. And until we do, no one's ever going to tackle it. And life's a death sentence. I mean, you know, we could all be under a bus tomorrow and not know it. So you're given a diagnosis, you know, oh, next time. But as I said, the key message is that it is not a straightforward clinical line for each person. You may be diagnosed with MCI due to AD and stay stable for many, 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 many years. And something else is going to carry you off, not the AD. So, you know, it's sort of one of those paradigm shifts we must engage with. No, it's not a death sentence. No, it doesn't mean you're going to be a slobbery mess in the corner in 1 year. That is absolutely not the truth of the matter. And there is so much you can do and so much support. And you're right. We also have to focus on the family of people, the younger ones, because otherwise they're going to be sitting there with that sort of free-floating angst about, is this my future? Is this what I'm going to end up with? Is this going to happen? Or does it impact my ability to do my job if I then have to care in a more, you know, intense way in the future? So it is everyone's story. As the Scottish, you know, dementia strategy was set out, they called it everyone's story, which is very cool indeed. Because it is. This isn't something we can just pocket and say, oh, this is your problem, or this is this group, or it's the oldies, you know. It's not. It's all of us have to sort of tackle this. So it's sad that you still hear that now, but thank you for sharing that, Ruth.
Yeah.
We have more questions. We
Lady.
have more questions.
Oh, we have more questions.
Do you know this person? Have a guess.
Harry.
I am not Scottish. My name is Sirpa Tapanen. I'm from the POISE project. Do you cooperate with any quality of life for caregivers projects external to your company?
Jeff?
Not currently, but certainly open to the idea.
Mm-hmm. Mm-hmm.
Let's talk.
Yeah. Good question, thank you.
Any others?
No. Please also feel free to reach out and contact us, okay? We're easy to find if you want to discuss anything or how we can maybe engage with your organisations or help or talk further about the diagnostics or potential treatments, or just even including your voice in all our sort of research we're doing. We'd be delighted to hear from you. So please I know sometimes you don't think of something in these sessions, but afterwards you think, oh, I should have asked that, or maybe that could be useful. We're always open to having a chat. We are in Scotland, but we do travel, and we have quite a few Scottish cohorts here, so reach out to anybody that you know that can then put you in touch with us. We'd be delighted to chat further. And again, thank you so much for coming at the end of the conference, all the way down the end of the hall.
So I have a question.
Yeah, go on.
I have a question, and while I'm asking that, maybe just two things. So one, if you would remind, please, that you have the questionnaires there. It'd be really good if you could fill those in. Doesn't take too long. And maybe leave them before you leave the room. And for anybody who's online, there are 22 people online. If anybody has a question, just please put it in. We've got another 8 minutes. So I think my question, and I think I mentioned when we spoke earlier last week, was so I've been working with Alzheimer Scotland for 23 years. I know there's a lot of people in here who have worked for similar organisations for a long time as well. And the last time a drug was licensed for treatment for Alzheimer's disease, if I remember correctly, was in 2002.
2003.
2003, right, so 20 years ago. And I think and I suppose what some of my colleagues here have said, is that the mainstay of care and support and treatment of people living with Alzheimer's and other types of dementia has been other human beings. Mm-hmm. It's been that social connection, and I think that remains absolutely critical. And when people do have a diagnosis, we're still diagnosing people quite late on in illness, so there's an ambition here to move diagnosis much earlier, because the potential treatment options that are in the pipeline are perhaps much earlier in the disease process. And I absolutely agree with much of what you said about how we can support people, but the truth is we're still diagnosing people quite late on. And actually, some of what you were describing there, that ecosystem of support around those people, that fabric of that started to break up long ago. So once people get a diagnosis, their family, their friends, the friends that they socialised with, that they played golf with, the people they went to church with, or whoever, start to lose the confidence as how to start to be part of someone's life. And sometimes what's happening here is organisations like the meeting centres and Stand are trying to put that fabric back together actually and create something in its place through new community connections and peer support opportunities. And I think that's really critical. And whatever happens in terms of any future treatments, these two things have to go absolutely hand in hand. My question, I suppose, is around diagnosis. Sorry, it took a long time to get there, didn't it?
That's all right, it was all very interesting.
Yeah, people do say of Jim Pearson, he likes to take the scenic route. But I think the question for me is, it's highlighted in your own slides there about the numbers of people who don't have a diagnosis. And in Scotland, we still have a challenge in terms of getting diagnosis. But the barriers to diagnosis are multifaceted. Mm-hmm. And the slide that you had, Jeff, around that diagnosis, and I know later on, I think it's acknowledged in some of your slides, and it talked about what people experience after that. And even the one about the journey, and then straightening it out, I think for me and for my experiences, that process from people becoming concerned, either they or somebody else in their family or circle might have a dementia, is never straightforward either. And even when you're armed with the right information and you have a family dynamic, it isn't always easy to take the right information into that environment and have a good quality conversation about dementia, because it's informed by so many things: fear, stigma, negative perceptions, the concern that there's nothing can be done for all of those things. And I suppose my question relates to that. How does what we're talking about here, how can that support and start to break? I know, there's a lot of facets to that, but what do you think you can do as an organisation that can help break down that fear and anxiety, or some of those barriers that prevent diagnosis?
Yeah, no, it's a very, very complex question. I'll try and answer it fairly briefly. There's a lot of things that need to happen hand in hand to make this work. One is the availability of treatments. And a lot of the reticence to diagnose or do anything was because there wasn't anything except the very old drugs, and now the new anti-amyloids that aren't approved here yet but are in the US. And unless you've got treatment options, clinicians, doctors are loath to diagnose you because they think I can't do anything, or I'm not going to take the time it requires to diagnose you. Dementia is also the great pretender clinically. So a lot of people don't present going, I think I have dementia, like I think I have a stomach pain, or I think I have a wart on my foot, I have whatever, it's clear cut. It can present as withdrawal, apathy, depression, all of the things that Jeff was talking about. It can present as a personality change, especially frontotemporal dementia, which affects younger people. It's a different area of the brain being affected, and it's people's emotional responses or lability rather than a memory issue. So it can disguise itself in so many ways, and unless you have a physician who is astute enough to pick up on that, it's going to be missed, or you're sent off to the psychiatrist, or you're sent off somewhere else, not to the appropriate person for diagnosing. People also hide it very well. They will wait for a cue. They're a little forgetful on name, and they'll think in the conversation, they'll wait till someone says, "Oh, yes, Jim, how was your golf day?" "Oh, Jim, right." And they'll do this too. And this all ties into it too. So unless they're prepared to understand or acknowledge there might be an issue, it's very hard to diagnose. And as you were saying, you don't drag someone along to the doctor because you think they're being a bit more forgetful or irritable. And the other key thing is it's not normal ageing. And that's one of the great myths of dementia and Alzheimer's particularly, that people think this is normal ageing process. It's not. It's a pathological process. It is associated, yes, with increasing age, but it's not normal ageing. So there's a whole spectrum of things that need to go hand in hand. And the diagnostics, including the blood diagnostics, when the blood biomarkers come in and we remove the need for lumbar puncture and CSF, and we remove the need for expensive PET scans, which are also invasive, expensive and hard to get, that's when we're going to be on the road to really, really getting this under control. So a treatment, understanding by not just the patients but by the physicians who need to treat them, and an easy diagnostic, that's when we'll get there. And we're heading there. We're not there yet, but we are heading there. We really are. So it's just a matter of, keeping the faith and hanging in there. There's so many people working on all of these things at the moment.
Yeah, I think one other key point is also, as we do the home assessment, that then this doesn't end there. It's not that's your score and that's finished. It signpoints to resources, signpoints to, that doesn't have to come from us, but we can signpost, for example, to reports about risk reduction and what can people do, other resources like the helpline that you guys have. That's where we see our role, not as we solve all the problems, but our role is we've got that home assessment tool, but then we signpost to other resources. And that has to be different in different regions because what's available is obviously different in different regions.
Yeah. It's an all-in effort, isn't it? Everybody.
We need to watch your time, but I think the assessment tools and that kind of the discussion to the video about something that's not so much of an intervention, it's not a stressful process, I think it's really valuable. I have one question in the chat which I think is probably important, since people in the patient, I'm not entirely sure whether you'll be able to answer it, but with the relationship of inflammation with the onset of diseases, are you aware of any research into how better food and exercise can help?
There is actually a lot of research done on this. There were exercises in people who had AD, study done of the effect of exercise in people with AD. So people are looking at all of these things. It's like, in general, the general good health, it's good common sense, like your grandma probably told you. Good sleep, good diet, good exercise, all those things, and keep yourself occupied. Humans are designed to move. They're designed to want to do something, to move, to stay active, to stay engaged. That's how we are. So that is all really, really good stuff.
And that's absolutely the premise behind the 12 modifiable risk factors, the finger study that we've heard of. Alzheimer Scotland has established Brain Health Scotland. A lot of our work is around prevention, risk reduction. So it is now coffee break. Can I thank our audience? Can I thank our speakers? Can we have a round of applause for our speakers? Thank you very much.
Thank you.